Hi, everybody, and welcome to the first recording of today's on July 22nd. By now, you should have read Chapter 26, Value Added Services as a Component of Enhancing Pharmacists' Role in Public Health. And one of the reasons why I had you look at this chapter and we're doing this talk is that as managers and goals to, become leaders in your organizations in community pharmacy, we want to look at where is community pharmacy going. And as you're working on your strategic plan that you're going to be presenting on August 5th, hopefully this lecture will help provide you with some thoughts of where you want your strategic plan to go. And as we are trying to broaden community pharmacy into being part of not just a standalone island where the distribution and patient safety of medications, we're also play a role as pharmacists, as the educators, as ways to enhance patients' health with other healthcare providers through our knowledge of the medications that can help improve clinical outcomes. So this lecture is going to focus on a couple things. We're going to talk briefly about the evolution of value-based healthcare and the role of pharmacists in today's outpatient healthcare. We're going to talk a little bit about how MTM principles, can be applied anywhere within the system. And we're going to discuss how these skills are the cornerstone of all clinical services in improving patient outcome. And we're going to look at how the future of possibly pharmacy enhanced networks may play a vital role, and ways that there are opportunities already at our hands that we may want to try within our organizations to help enhance patient services and obviously maybe enhance the revenue and the profitability of our organizations. Regardless of where healthcare is going, and we know that we're in a turbulent time of whether or not the law of the land of the Affordable Care Act stays or goes, or some modification occurs from it, we have developed over the last 10 to 15 years of going more from a fee-for-service type of payment system in our healthcare system to more value-driven healthcare. And value-driven healthcare is basically finding a balance of the quality and costs that can help improve quality while reducing costs. If you've learned in studying, the evolution of our healthcare in our country, we know that we are one of the most costly healthcare systems in the world, with probably some of the poorest outcomes in terms of quality of life and life expectancy. The problem that we have is as a society, we try to implement value-based healthcare, is that the challenges is what can we agree on how to define and measure quality, that what we're doing actually is making a difference. So we have to think better, smarter, and healthier, improving the way we are incentivized to deliver care, and way that we can distribute information to the patients, and through that information and through different type of clinical programs, we can provide better care at a lower cost. And so when we look at, what's been studied in terms of value-based payment goals, there's goals of the providers who are paying for it. There's goals of how do we deliver this healthcare and actually distribute the information. A health system that provides better care spends dollars more wisely and has healthier people, studies have shown. And how do we incentivize us as providers? How do we incentivize our patients? And we've already seen this incentivized in the Medicare star ratings that I know that you are all familiar with. And also, we have seen these incentives occur in the hospital systems and physician systems and the healthcare payers. The other areas is how do we deliver this care? One of the things that I'm going to stress numerous times through this lecture is we as pharmacists, being in community pharmacies, touch the patient multiple more times than any other healthcare provider. However, we're probably the most underutilized source in being able to deliver this care. The other thing is what care we bring. How do we deliver the information of what we're doing to other healthcare providers to make sure that we are showing what's happening to help continuity of care across all venues, whether it's the pharmacy doing it, the physicians, the hospitals, home health. And so how do we can put all of these together? We know as pharmacists and the pharmacists that we oversee that we are well trained as we come out of pharmacy school. We are loaded with tons of knowledge, from disease state management skills to pharmacology, kinetics, dynamics, pseudocics, and pharmacotherapy. Probably one that, some are better than others is our communication skills. How can we communicate what we know and our knowledge to our patients that we see every day in the pharmacies and other healthcare providers? And we know that often, because of low reimbursements to prescription drug therapy, that we're often, having to concern ourselves with, tightening of schedules, how many FTEs we need to schedule, because our current system is based on, how much we make on a product we distribute and how much we are paid by the provider who pays for it. I talked about this already, so I'm not in our earlier talk, so I'm not going to skip through. But we know that if we look at the history of pharmacy, we've evolved over the years. And we talked about this initially in our beginning talk. But we know that the future of pharmacy is not just being a distributor of medications, although we'll probably hold on to that role for many more years. And until we can develop a good payment system to be paid otherwise, we need to hold on to that model. But the future of pharmacy, we have to take a look at how can we provide these advanced value-based healthcare clinical services. The challenges that we are always facing is that there's financial concerns. Pharmacy, although it's multiple sales of what we make, is our gross margin a lot of times is not as great as we'd like it to be, and our net income is not as great as we'd like it to be because, reimbursements. Studies have shown through both NCPA and NECDS that for a pharmacy to be profitable, whether it's a chain or independent, the average cost of dispensing, when you include your labor and all the other operating costs to go into it, we at least need to make about $10 to $12 per prescription. But we're constantly being faced by slashes of healthcare, thinking it's very easy to just slash, reimbursements to pharmacies. We're currently, this is currently occurring here in Pennsylvania as our state legislators are arguing over a balanced budget. And one of the ones that they're focusing on is slashing the reimbursement of pharmacists in our PACE elderly program. The challenges that we have in healthcare is this. If you think about the pie of what it costs to take care of a patient, only about 10% of healthcare goes towards the medications. When you factor into specialty, we may get that up to around 17%. So only anywhere from $10 to $20 is being actually spent on the medications. However, the medications is one of the biggest things that's impacting the other healthcare costs. I've said this numerous times, possibly to you guys in lecture, but I've said this to other classes that I've taught. If you think about medications, unfortunately, we do not really cure a lot of diseases. We cure some, we cure infections, and we cure some cancers, not enough. But most of our medications, what do? They either prevent, control symptoms, or slow the progression of a disease. And by preventing, slowing progression, or treating symptoms of disease, hopefully it helps decrease that other part of the pie, the costs such as hospitalizations, ER visits, and readmissions. And then, while prescription drugs account for only about 10 to 15% of healthcare spending, pharmacy's ability to affect costs isn't limited to drugs alone. if we were given the authority and reimbursed fairly, numerous studies have shown that we could possibly contribute to the reduction of that other portion of the pie in healthcare spending. And this is where we as pharmacists are starting to see the evolution of clinical services on the outpatient setting. We know for the last 30, 40 years, we have shown numerous savings for clinical pharmacists in the inpatient setting in preventing length of stay and reducing costs, ADR, adverse drug reaction costs, or drug costs in the hospital setting. As we are here, as I said earlier, in this value-based healthcare system, that we have to think about how do these services that we want to implement. Obviously, as a business, we're thinking about, can we cover our operating costs to be able to afford an advanced clinical service, and what is the ROI, return on investment? But we also know that not just the star ratings that we see in the Medicare plans, we know that other health entities are being pushed from the historic fee-for-service to this incentive payment system. However, a lot of times the impact that those other healthcare entities can have on a patient is not as well versed as a pharmacist could in terms of the education, the monitoring of adherence, the monitoring of device techniques in different devices such as inhalers and asthma and COPD, as a pharmacist can be. So we have to think about, here is our patient, and our patient touches numerous different parts of the healthcare system. Primary care, the PCP, specialists, hospitals, and pharmacy. And we as a pharmacist, we touch the patient numerous more times than any one of these other healthcare entities. And we need to start looking at, how do these services do we develop integrate to be part of the pie, not standing on an island as a service just to sell within our business, but how can this service offer to improve outcomes with others? The biggest thing that holds us back, obviously, is that we as pharmacists are not healthcare providers. And as we push through our numerous organizations for provider care status, and I believe truly that someday we will have that, we have to look at different ways that maybe through different networks, different programs, that we could be reimbursed currently, whether it's through collaborative drug therapy management or whether it's through provider care networks. This is just a listing, and this is a couple years old, but this is a listing in 2015 looking at all the different incentive programs coming from CMS. And if you look here in the hospital setting, we see hospital readmission reduction program. This is where we've seen the evolution of transition of care programs, where pharmacists are offering, bedside delivery, doing 48-hour follow-up phone calls. We see down here where we've been impacted over the last 6 to 7 years in pharmacy with the Medicare star ratings. And what have we done to help impact that? We've developed synchronization programs, we developed adherence programs to do that. Because what can we impact and how do we measure success? So as you're doing your strategic plan, how do you think you will measure the success of your program? And the biggest thing that what has been shown in numerous studies, and if you haven't done so already, as I said, please research what has been studied about your current program you would like to implement. Because you'll find that a lot of the things that you're trying to do, studies have been done, and where have they shown the biggest impact? Obviously, one of the things that's interesting, they've actually shown that pharmacy services have increased physician utilization more, but that's okay. If the patients are seeing their PCPs at follow-up regular visits so the PCPs can identify problems before they get worse, that's okay. Drug costs actually will go up. Why? Because we're improving adherence. But the most costly things that will go down is inpatient admissions, preventable admissions, and emergency drug visits. So the big picture for the now and the future is obviously both through both in the chain industry and in the independent pharmacy industry, NACDS and NCPA and your pharmacy state associations are always fighting and working with in preserving product reimbursement. The other thing, we're always working in to make sure that we can possibly be part of the different networks and we're not excluded from different networks from PBMs. The other thing, that if we're going to be part of these networks, we may have to show that we can improve star ratings such as adherence. But as we go and evolve these different community pharmacy programs, we need to develop what these clinical programs can provide as a care team dependency. How does your programs you're strategically developing impact your physicians in the area, your hospitals in the area, your home health care? Can you possibly reach out to them? Is there possibilities for other reimbursements? And where those reimbursements probably need to come in the future is not from the PBM side, but establishing relationships and reimbursement models with the medical benefit side. Remember, every one of us is a team member, from pharmacist to technician to the front-end clerk, to make a difference in patient outcomes. So as you're developing your strategic plan that's due at the beginning of August, how are you going to incorporate those staff members to help with your program also? I've said this before, the North Carolina clinical network that's been going for several years, Troy Triggerstad, and actually he's had numerous articles published about pharmacy reimbursement. So if you'd like to research some of his articles, they'll be very knowledgeable of helping you and looking at maybe some things you can incorporate in your strategic plan. But Troy has a great saying: as long as you're providing value in the next 10 years in healthcare, you'll be fine. So as pharmacies, pharmacy business, pharmacy corporations try to position themselves, regardless of what the laws are occurring in healthcare, if we're providing value, we should be able to be successful. So let's look at the next learning objectives: reviewing MTM, medication therapy management principles, and discuss how these skills are the cornerstone of all clinical services and proven patient outcomes. Pharmacy laws have changed community pharmacy. The one thing, remember, and this is coming from Pennsylvania law, so bear with me for those who are out of state listening to this lecture, but as at every state, most state pharmacy acts make it unlawful for a person not licensed as a pharmacist to engage or allow another person to engage in the practice of pharmacy. Other things that have occurred over the years, though, is when Medicare Part D was passed in 2003 and implemented in 2006, we saw the development of MTM services. And in 2013, that law was enhanced even more to standardize what goes along in an MTM. Other codes have occurred in states, and you need to rely on your state law for this, but almost all 50 states, actually all 50 states, I stand corrected, can immunize in some state of fashion. Some laws differ in how pharmacy interns are allowed to participate and what age of patient and what type of vaccinations can be given. Collaborative drug therapy management, which is a development of an agreement between a pharmacist and a physician to help dose adjust, disease state manage through protocols. Here in the state of Pennsylvania, we do have protocols with collaborative drug therapy management. If you're not familiar with collaborative drug therapy management, we can always do a more enhanced talk on that. And actually, if you're interested in it, I do have a taped lecture on collaborative drug therapy management. So just shoot me an email and I can send you a link to that lecture. But collaborative drug therapy management is a way that some of these clinical services that could occur now. And there are also different ways that pharmacists, through collaborative drug therapy management, may be able to, with a physician's practice, do what's called billing for incident, and billing for those services through the physician, and then the physician would pay you a consultant fee. And obviously, we are always pushing for pharmacy provider status. However, some states have become more advanced for this. The state of Washington, pharmacists actually are providers. And the state of Washington, just in the last year here, passed a law that said pharmacists have to be reimbursed as providers, even with private and government programs. California also has provider status for pharmacists. I know everybody knows what MTM is, so I'm not going to go through it in its entity. But as we know, one thing that what MTM did is although it's not as great as we'd like it to be in the 11 years since its implementation, but it has helped standardize what we do clinically. Clinically, we're evaluating not just one drug. We're not patient counseling on how to take the drug for the first time. We're evaluating the overall patient of their medication regimen. And for your programs that you are developing, your strategic programs, think about every one of your programs could involve some type of MTM assessment skills in them for the pharmacist to do. Whether they're more intense or short acting, they can do that. Because the ultimate goal of an MTM is to do a good med review with the patient, assess their knowledge of the drugs, and to also assess whether there's any bad things happening with their drugs, to optimize medication use, improve collaboration, enhance communication, and empower patients. We know there's different vendors out there, and you guys are probably familiar with the MRIXAs and the outcomes that do that. And as I stated before, Pennsylvania Pharmacy Clinical Network we have developed an internal network here in Pennsylvania. North Carolina has done so too. But these networks allow pharmacists to get together to negotiate with providers to offer clinical services and develop payment structures. So we know that community pharmacy is evolving. And what are some non-product revenues that we are seeing in the industry? MTM programs, adherence programs. Although synchronization we're not really charging for, I've seen more advanced adherence programs with specialized packaging, delivering, that some pharmacies have been charging for. Diabetes education programs, collaborative drug therapy management, transition care, and genetic testing. And we're going to touch briefly on some of these. But remember, MTM skills, one of the things you as a pharmacy manager will be in charge of is to evaluate, are your pharmacists trained enough, skilled enough, and what will your ways that you'll measure their success? What metrics will you use to assess their skills? Obviously, there's workflow skills because it's still costly to pay a pharmacist, and a clinical service is only going to be reimbursed so much for so much period of time, and so you must be able to make sure you evaluate that. But like I said, if the pharmacist is doing their job and are highly skilled and trained to do those goals as I mentioned, that this will help improve that. And we as pharmacists are already doing this every day. This comes from a study I did years ago, and I mentioned this in a previous talk, that I looked at all the different times a pharmacist did an intervention in the pharmacy, and I compared, I studied two pharmacists, one from a chain and one from an independent. I didn't compare them direct. I just compared how many interventions they did over a 3-month period. And both pharmacists did close to 1,000 interventions, and they identify those every day when they're filling a prescription. So drug therapy problems is right in front of our computer terminals every day. The question is, what programs can evolve out of that identification, and can we actually be reimbursed for those outside of the product? MTM, as I said, has standardized. The requirements are that a pharmacist do a med review, provide the patient with a personal medication record, provide a patient with any actions they may need to do, document to physicians any interventions or referrals. And I think this is probably the biggest challenge we have in our community pharmacy is how do we standardize documentation? How do we integrate with electronic health records with other healthcare entities, that this can be a smooth transition? Because obviously, as I said before, you have to think about your ROI from a pharmacy side point. And next semester, when we get into financials, we'll actually look at ways we can evaluate this financially and study this. But different documentation systems can be costly. You want something can be part of maybe the workflow or part of a quick process that the pharmacist can get this job done. As I said before, currently with the contracts we have with the Marixis and the outcomes, we're offered, we can do these CMRs, which in my opinion, a full CMR should be about a 20-30 minute process. A TMR, which is a lot of times star rating targets, adherences, those should be done within 8 to 10 minutes. And so having pharmacists to be more efficient at these, and how do you measure that efficiency, is something we as managers have to incorporate. As I said before, the one great thing about MTM has done, and this comes from the Joint Commission for Pharmacist Patient Care process, as I said before, there's numerous steps that we do, and regardless of which program you're developing in your strategic plan, your program, from a workflow standpoint, the pharmacist is going to do some type of collection, assessment from the patient, or a caregiver. You're going to assess what needs to be done. And then there's going to come up with a plan. And in that plan, obviously is where we document. One of the things just to share with you, I might have mentioned before, is when we talk about how we get paid for medical services, clinical services, if you look at the physician world, whether it's physicians, nurse practitioners, physician assistants, they're only reimbursed for the time they spend with the patient. And so that's why efficiency, as I keep saying, that I hope to see in your strategic plan how you're going to evaluate your efficiency, what your workflow going to look like for your program. Because, the planning, the documenting, and then implementing, whether it's contacting the physicians, whether it's contacting other healthcare professionals, contacting the patient themselves, and then the most important thing that our current MTMs that we see with Marixis and outcomes don't always do is that there has to be a way that we can follow up and monitor the success of whatever program we want to implement. I'm not going to go through this. This is that case example I gave you. I gave you that as an example when we were doing HR. But you want to see that your pharmacist, the point what I have these is your pharmacist is skilled enough to identify drug therapy problems just by doing a med review. Are your pharmacists skilled enough? How are you going to evaluate their skills for doing a med review? How are you going to evaluate their skills for documentation? And this is a new great unknown in terms of hiring. If you've never hired clinical pharmacists, obviously you're going to look for references and their knowledge base. But most of the time when clinical pharmacists interview for positions, whether it's in the academic world or it's in the clinical world, a lot of times they have to do formal case presentations. And I think in the formal case presentations, you get a little test of their knowledge. And obviously in those type of interviews, you would want to have people that are also clinically strong that they can counter with questions. And this is just another tool that's been used over time. It's called the MAI tool that assesses, all the things that go on in MTM. That does every drug have an indication? Is it effective for condition? Dosage correct? Directions correct? Directions practical? But this is a good tool. I throw these tools in here, and that case example is that we as managers, we constantly have to be evaluating the pharmacists that we are hiring. Are they skilled enough to perform these tasks? The other thing that we have to measure, whatever our programs are, is the outcomes. The three basic outcomes that get measured in any type of clinical service that you see on the medical side of healthcare is economic, clinical, and humanistic. So in your strategic plan, how will you track outcomes to show the quality of care you provide? What can be monitored and evaluated? What processes will you measure? What patient outcomes will you measure? And who is measuring, what's going on in the pharmacy? Obviously in the economic, we look at the ROI. What is the money gained or lost based on financial investment? Sometimes ROI, when we're dealing with other healthcare entities, can look at the cost savings on medical or pharmacy expenses. In the community world, still, remember, we're product driven. So if your program helps improve adherence, or there's other products that you might be selling with that, what is the revenue and sales that you're bringing into that? If you're able to be part of a network or develop a collaborative therapy management program where you can work with physicians to bill for your services. What is the break even point for those? We'll go more into those financials next semester, but start to think about those. Clinically, that's usually not the easiest, but one that we can really identify. So if you're doing a diabetes program, you can get a baseline hemoglobin A1C, and then you can remeasure that hemoglobin A1C, within, 3 months. If you're doing a blood pressure clinic, you can evaluate the person's blood pressure. So what disease-specific measures? Or if you're doing smoking cessation, evaluating, last time they had a cigarette. You're doing weight loss, significance of their BMI changes. And obviously, another thing that we see this in the hospital setting is that the humanistic side. So doing quality of life surveys, physician satisfaction, pharmacist staff perception satisfaction types of surveys. So as I said before, economic outcomes, just real quick, looking at return on investment. As I said earlier, if you're working with our other health entities, how have you decreased, possible hospitalizations, ER visits, measuring prescription costs, clinical outcomes, disease-specific measures such as A1C, lipid profile, blood pressure, INR, instance of bleeding events, time period of INRs within range, for an anti-coag clinic. And so those are clinical outcomes to measure. Humanistic, patient satisfaction surveys, health-related quality of life surveys, staff perceptions of the practice types of surveys. So there's numerous types of surveys. Other things such as sick leave measures, increased work productivity, lots of different measures we can look at the humanistic side. As I said before, whatever your clinical service is, it makes sense. If we put them on the right drugs, if we make sure that they're adherent to those drugs and no bad ADRs, adverse events, are having to those drugs. If you look at Medicare, covering a drug that's going to do all those things, obviously we should see a reduction in the hospitalization side, such as Medicare Part A. An example of this is, now these costs, bear with me, the Advair cost is probably a little bit more expensive, but the cost of the year of Advair is about anywhere from $4,000 to $5,000. One length of a hospital stay for asthma can be around $11,000 to $15,000. And so if you had a program to help improve adherence, to help improve education, you could show a significant, benefit in being paid for just a small fraction, to help implement one of those programs to decrease hospitalization. Another could be ADR prevention, having a program focusing on geriatric patients who are fall risk. Getting rid of certain drugs could have an impact in lots of costs that occur with this. So let's discuss about ways that's evolving across our country in numerous different states and even on a national level of these enhanced pharmacy service networks. Here in the green are the different networks that have been evolving over the last several years. If you see, and actually one of the ones that is not highlighted is the North Carolina one, but the North Carolina one is was more government based, not state association or school pharmacy based type of network. Another report that came out in 2015 at the National Governors Association was they were stating that they would like to see pharmacists more integrated into the healthcare system. So this was a great knowledge boost coming from all governors across the country for pharmacy enhanced services. And just this past fall, NCPA, along with the North Carolina Enhanced Network, is trying to develop a national network for pharmacy enhanced services. There was one a couple years ago called Align. Unfortunately, it never really took off and kind of went out of business. But I really believe this one is actually making a lot of steamway, and you may see this enhanced network. And this is not just including independent pharmacy, it's also trying to bring in chain pharmacy along with that to develop national networks for national contracts. Wisconsin has done one for several years. They do it through their Medicaid program, And this is just showing you how many pharmacists have been involved, how many patient lives that have been completed. Minnesota has a current plan too. Minnesota actually is unique. It actually has written in the state legislation on the reimbursement for pharmacists. And 1 MTM for a pharmacist is actually around $140. And for every intervention is anywhere from $20 to $75 for the intervention. So they created a medical benefit model that would incentivize pharmacies to want to participate in the program that could justify a decent ROI for pharmacies and pharmacists to want to participate. As I said before, Pennsylvania has, in the last several years, been developing their own network. Because one of the things, if you look at, and I know the health bill and the state Senate bill is different, the numbers right now nationally on the pharmacy provider status. When the pharmacy provider status first comes out, when it does get passed, it's focusing, we're kind of following the nurse practitioners of how they got provider status. It's focusing on just the medically underserved areas for pharmacy. And if you just take a snapshot here of Pennsylvania, those here in the green are the medically underserved areas. So there's numerous parts of our state in Pennsylvania, I'm just using them as an example, where we wouldn't be still servicing people under a pharmacist provider status. And that is why these care networks can help develop a network where pharmacists can provide services. They can negotiate with payers. They can also train these pharmacists to make sure the quality of these pharmacists are up to snuff. And we don't have to wait for provider status for this to occur. Obviously, provider status will help in the long run, and so we need to keep pushing it. But, that is the goal. What PCCN has done over the last couple of years, they developed a standard process of care. There is actually a training program that all pharmacists go through. It is about six hours online and 3 hours live. There's a mentor collaborative to work with these pharmacists to enhance to help as a safety net for them as they're first starting to do these services. And what the goal of the PCN is to get numerous pharmacists. And this is just a picture of all the different pharmacies that are involved. And currently, and let me step back here, these are all independents right now on here. But here in the state of Pennsylvania, we do have Giant Eagle Pharmacy as a chain that's involved in Wise supermarkets, and hopefully hoping to get other chains on board in the near future. There is actually going to be an announcement this coming week that the first payer contract is going to be available for pharmacies to participate here in Pennsylvania. So networks is another way that a service of a way you get paid. And what happens in that network, the pharmacies would sign a contract, and the network has also worked with another company to develop a documentation system that the pharmacist would use, similar to a Morexa, that would allow payment for these services. And then the other responsibility of the network on the back end is to start measuring those successful outcomes, such as decrease in ER visits, hospitalization, and other costs. If you think about yourself and your role in your community pharmacy, what areas could your pharmacy possibly get involved in? And I touched based on a little bit of this, occurring. These are the programs that actually my pharmacy that I work with, we do right now in the red. We do immunization. We have a sync program. We are going to be participating in the PCCN. We currently have a transition of care program, and we have a diabetes education program that we've had, but we're going to be getting certified to bill here in the near future. And we do have a collaborative practice program with one of our primary care physicians. So how do these services improve patient outcomes? Obviously, we know that immunization is a preventative service, and immunization has probably laid the groundwork for all pharmacies, whether chain or independent, because it was the first even though we're getting paid for a product, think about we're also getting paid an administration fee. And it's the first time pharmacies were doing a service outside of distribution. And, if your pharmacy is not doing more than just flu vaccine, I encourage you to take a look at that. We actually have two physicians that actually came to us over the last couple of years and said, I don't want to do our immunization anymore. And we actually do all their immunizations. We have a good documentation system where we're forwarding that all to the physicians. We're making sure that's getting recorded on the state level. Adherence programs, we know most of all pharmacies have some type of synchronization adherence program. Obviously, that's a win-win for both. You know, it helps the patient. It's still helping your bottom line, the prescriptions filled. It's also a time, too, is that maybe you're losing money on a prescription if you have access to costs and reimbursements. And if a patient is not adherent to that medication, maybe you can find a medication that is just as appropriate for that disease state, but it might be a win-win where the patient can afford it and maybe it's a better reimbursement for you. Obviously, you know, MTM type of programs. Unfortunately, the Mirixin outcomes, the reimbursement models are not probably as cost effective as we'd like them to be. But I still believe that we need to do them. There are ways that we can also help our patients through synchronization, ways to identify patients that may need to be immunized. And so there's numerous ways for that. I encourage too that maybe there's ways to explore community partners. Hospitals, physician practices, home health services are all filling this value-based healthcare pay-for-performance type of network. And through your programs, you may help to establish a partnership that will be able to do this. And so if you can establish yourself as a pharmacy that can be integrated as part of the healthcare system, especially with these new services, there's opportunities through collaborative practice to be doing billing for that. Obviously, we know, adherence programs is a key cornerstone that we as pharmacy can help with. Collaborative drug therapy practice, as I said before, what it is developing a collaborative practice where the pharmacist and the physician go into agreement that would allow you to do dose adjustments. Here in the state of Pennsylvania, the only thing we're not allowed to do is initiate new therapy, but within our protocols, say for example, it was a protocol for diabetes, you could do dose adjustments with insulin. You could do dose adjustments with warfarin. This is a picture on the right here of Dr. Miller. This is the physician that I work with in my one pharmacy. He's a rural physician, and we have two collaborative practices with him, one with immunization and another one with high-risk geriatric patients. Numerous of these clinical programs have shown costs. This is a study that was done by CVS, and it showed, this is looking at transition of care, and it showed that the program saved $2 for every dollar spent on pharmacy. So there's numerous studies out there to support for what you do. And nearly 1 in 5 Medicare patients discharged from hospital are remitted within 30 days. And so, I encourage that if you have not looked into transition of care programs, this is a great opportunity. University of Cincinnati showed an estimated 20% reduction in readmissions for patients receiving counseling and medication management. And in that study, they actually collaborated with Kroger Pharmacy chain to help implement this program. Another program that's a little bit more intense is the Diabetes Accredited Standard Practical Application, DASPA. And this is an opportunity for pharmacies to get certified to do diabetes education. Why is this an opportunity for pharmacists? Well, there's a growing number of people with diabetes, a declining number of endocrinologists and CDEs, certified diabetes educators across the country. A lot of hospital programs aren't offering diabetes education programs, and if they are, they're kind of not always at the best hours that a patient can attend. And there's only a small percentage of patients that receive self-management training. What diabetes education? It's not MTM. It's a comprehensive collaborative process for working with people who have diabetes in the area of nutrition, medication taking, and physical activity. So it's much broader than MTM. And obviously the goal is to achieve optimal health status for a diabetes patient to improve their quality of life and reduce healthcare costs. If you get into doing diabetes education program, The way this program is through the American Association of Diabetes Educators. A pharmacy can get certified to do this. You have to have protocols. You have to have different you have to develop a curriculum, and this curriculum has to focus on these 7 things: helping the patient improve healthy eating, helping the patient become more active, educating the patient how to monitor all the different things that occur, not just their blood sugar, but risks for foot infections, getting eye exams, understanding their medications, how to problem solve, such what do they do when they're hyperglycemic, how to reduce long-term risks, and health coping. The requirements for pharmacies to provide this is you must be served by one of the national crediting bodies accepted by Medicare, and I list them both there. The American Diabetes Association of Education Recognition Program, and I think the easiest one is the AADE, the American Association of Diabetes Educators. Who qualifies for this education? Right now, if you get certified, the first place you try to then is you can bill Medicare. And if a patient has never had a diabetes education program and you get a physician order and they have a diagnosis of diabetes, and they also qualify for Medicare Part B, they can have up to 10 hours of diabetes education. If they've already had a diabetes education program, they qualify for 2 follow-up hours per year, but they must have a prescription referral from a primary care provider. The program is usually 10 hours. Like I said, there's opportunities within the pharmacy besides doing the diabetes education. You may capture their meter and strip business, OTC medications, selling them diabetes, products, smoking cessation, and therapeutic footwear. And like I said, this is an opportunity for pharmacy. These diabetes education programs have shown decrease in hospitalizations and ER visits. They've shown an increase in monitoring and appropriate prescription drug use. Just getting back to this, the ultimate thing too is the way Medicare reimburse. To do this as an individual program, I will give you my opinion, is not really cost effective. However, you can do group education, and depending upon where you're at, if you do group education, if you'd like to know about the dollars, I can talk to you, one-to-one when we meet again. But to do group education, as long as you have 4 or 5, 10 is probably optimal. It can be a profitable entity, whether it's a pharmacist or a dietitian providing the education for that service. The current program that I've developed, it's myself and a dietitian and a PA that we take turns in the education programs. Another area that NACDS has developed in a certification program is point-of-care testing. It all depends also on some state laws, but different states have allowed pharmacists to perform CLIA-waived tests, such as strep testing, H. pylori, HIV testing, influenza testing. And why would a pharmacist care about point-of-care testing? Well, I've seen Walgreens have done a couple of these programs in other states across the country where, with collaborative practices with physicians, they're able to initiate therapy, and sometimes they're able to, and in these different states, they're actually able to bill for the point of care testing directly to the healthcare provider. Once again, it's a different type of revenue. I encourage you, if you've never gone through the program, I know Duquesne University puts one on so many times per year. They're certified, but it's actually done through NACDS that does this point-of-care testing. Another area is pharmacogenomics that is growing. Obviously, community pharmacists can routinely perform point-of-care services, as I mentioned before, but there is a way that pharmacists, through collaborative practice, can actually get paid for not just doing the swabbing, but doing the genetic review in conjunction with physicians. So let's look at the last step: identifying important steps to getting started and offering clinical services in a community pharmacy setting. The simple steps for successful community pharmacy practice is whatever program you're going to develop. Remember, success is doing those common things uncommonly well. That is why, as we said earlier, strategic plans work. Finding pharmacists who have a passion for this. The pleasure in the job puts perfection in the work. And as I said before, from customer service standpoint, you can sell these services because there's two things people want from a business or a service. They want to feel good and their problem solved. What forces restriction for pharmacy clinical progression? Obviously, is the legalities that we have, state scope of practice, provider status. Obviously, how does your program market for patients to accept it? How do you market to other healthcare providers? What credentialing might need to be involved? What future liabilities might you need to have to prevent risk? And what is the time restraints that limit your ability? What determines your clinical ability is the pairs when you're developing your job descriptions. What's the education or training background you want for these pharmacists? What experiences and what practice environment? If they're non-pharmacists too, what is their clinical ability to contribute to your program? Thinking about your workflow. As I said in an earlier talk when we talked about workflow and operational management, think about what we've done in the daily dispensing of prescription. So what is our clinical community workflow? What does it look like? And how are you going to implement your program? Obviously, things that hold us back might be lack of knowledge of how to set up a service. As I said before, as you are developing this plan, think about researching what programs have been done before, developing a profit structure model to financially support this. I think in 2017, we are set up more than any to possibly make a profit structure in these programs. Not able to free up my pharmacist from the dispensing role. Obviously, these programs initially, we're not going to possibly be able to afford a full clinical team, but it takes time. And getting patient acceptance that this is what we as pharmacy do. How many of you remember when you first did your immunizations, if you were involved with it, that they asked, I remember when I did my first shots for a patient, they asked me, so how long have I been a nurse? So the future is now, all right? That there's numerous opportunities for us to implement programs. Thank you for listening. There's the questions that I have at the end of these slides. This comes from a CE program that I've done prior to that. I've created this into a CE program, but you're more than free to look at these assessment questions, and we can discuss these when we meet live in a couple weeks. I thank you for your time and have a good week.